Hi, everybody. Glad you got some coffee because I'm going to be talking about Medicare, so we all know how exciting this is. The clicker. Did you guys move the clicker? It was up here for the slides. Just going to use the arrow. The clicker was, it was here, now it's gone. All right. So this is just our normal disclaimer slide. Everything always changes with Medicare, as everybody always knows, so make sure that you're constantly checking the websites. When we were asked to kind of present, I was thinking about what secrets to success we could give you guys for Medicare, and I guess the best that I could come up with was actually just understanding how to bill for Medicare and what Medicare actually covers when it comes to telehealth, the types of providers that they cover, and also the facilities. So we'll just kind of dive right in. This is the agenda we're going to go over today. I'm just going to go over an overview of what telehealth services are, as well as the difference between an originating and a distant site, and then give you lots of reminders and helpful resources if you are going to be billing Medicare claims for telehealth. So just a little overview of what we have. Medicare pays for Part B services that are furnished by a physician or a practitioner to an eligible beneficiary that is at an approved originating site. And it has to be via a telecommunication system. And it has to be an interactive, so both your video and your audio as well. And then also you have to meet your coding criteria for your CPT codes, and then the conditions of all of that payments as well. So Medicare determines the codes that can be able to use, because it's going to substitute what you're going to use for your in-person encounters. So it's going to be for your professional consultations, your office visits, your psychiatric services. There are limited fee schedules of CPT codes that you can bill that CMS has determined that would be an eligible code for telehealth services. They do have, every year they put out their final rule, and you as a provider can also go to their website and let them know if you feel like this code needs to be on here, there's a need for this service. You can definitely submit that to them, and it'll be reviewed to determine if that code can be a telehealth service. So one of the big questions that we always get is, and a lot of our claim denials, is because they're billing opposite. So your originating site is where your beneficiary is during the time of service. So it's not where you as a provider are. I know that seems to be a lot of the confusion. So it's definitely where the beneficiary is during that time of service. So that's determined by that rural health professional shortage area, which is known as the HPSA. And you can go out on their website and you just enter in the zip code, and it'll show you whether or not that where that location is an approved site. Or it can be in a county outside of a metropolitan statistical area. So these are all determined by these that you see up here, the health services and then the United States Census Bureau. They can change yearly just based on if any of the zip codes or anything like that have actually changed. So this is just the link, the screenshot of out to the IRSA website, and this will let you know. You just enter in the address, and then it'll let you know if that is in that HPSA area to where you'd be able to bill for those services. And the results, it'll give you a yes or a no, plain and simple, if that service is actually eligible or not. Another big question we get is what facilities can actually be authorized. So here's your list. You can have an office, a hospital, your critical access hospitals, your FQHCs, skilled nursing facilities. These are sites that are authorized by the program to be your originating sites. Sites not approved. CMS based the sites that are approved based off of the standards that that facility must have. So they're saying that these don't meet the statutory requirements for an originating site, which does include the beneficiary's home. There's an exception to this, which is for a new model that they are working on, and that's the CJR model, and I'll go over that on a few other slides. Independent renal dialysis facilities and sites within an MSA are not within a HPSA, and there also is an exception for the new model that they're working on with that. So this is if you're billing for your originating site for your Part B claims. This is strictly for Part B, so it doesn't have to do anything with your Part A services, your type of service, and then your place of service. And there really is only one CPT code that you're going to be billing at for the originating site for your patient, and that's just going to be your Q3014. And that just lets us know that this is the specific of what you're billing for. There's only one code that gets billed on the originating side. Facility fee, that's what you're paying. That's what you're going to be billing for your originating site. So here's your 2017 allowable. Their Q3014 is always what you're going to bill. So the distant site, that is where you as a provider, that is where you are, and this is the services that you are billing for. So your location is going to be your facility where you're at providing those services. That's where you're going to have your audio and video telecommunication systems. The beneficiary must be present and participating. There is if any of you bill for Hawaii and or Alaska, they are currently working on a new demonstration product that they're on how the communication can be stored, because right now it has to be done in real time. So they are working with Alaska and Hawaii right now for a possible store and forward technology. So stay tuned for that one. It is currently they are using it right now. There are a few different facilities out there that are working on seeing how this could work if we expanded it out to other states. So your payment is going to be based on whatever the fee schedule amount is for the code that you're billing. So if you're just billing for your follow-up office visit, your fee schedule amount is going to be the same. You're going to get paid for your office visit just as if you would if it were a face-to-face visit. Your service that you render still has to be under your scope of practice for your state law. And as usual, the beneficiary is responsible for any deductible and co-insurance, same as it would be if it was a normal face-to-face visit. There was a few updates in 2017, and I know that there is going to be some more that are coming out in 2018. There are some changes that are going to be in October as well, but they haven't released that quarterly release to us yet, so I don't have that information for you guys. But I know they're adding in some CPT codes that they feel that are telehealth appropriate. So take a look at this update that we have out here. This one was from January, so there was a new place of service code that was implemented for the telehealth, the distant site, and then also the CPT codes that were added. You can find them on this link out here. So here's just a chart of all of your eligible practitioners. These are the ones that now can bill for telehealth services. Your physicians, psychologists, your clinical social workers. For your psychologists and your clinical social workers, there is a little asterisk there that you cannot bill or receive payment for that diagnostic interview VAMs with E&Ms or medical services, and it lists those CPT codes. And all this information, I'm going to show you, there's a booklet that CMS has out on their website that it gives you a list of all of your CPT codes. So when you're submitting for your claim submission for your distant, you're going to make sure that you're billing with whatever CPT code that you are billing for, your office visit, your follow-up office visits, and then you're going to bill with your GT modifier, and that just lets us know that the beneficiary was present and eligible at their site. And then also if you're doing your ESRD codes as well, and that certifies that there was one visit per month that was furnished face-to-face. So you can't do, if you're doing your ESRD follow-up with your patients, you have to make sure that at least one of those visits a month is face-to-face. They did add some additional services. These are the additional ones that they added for 2017 that do have to do with the ESRD, your advanced care planning, and then also your telehealth consultation codes. So if you're billing for any of these services, definitely take a look because they did add a lot of CPT code changes for the beginning of 2017. GT modifier is mandatory on all claims when you're submitting them over. It lets us know that it was via that interactive audio and video telecommunication system. And it also lets us know that the certifying beneficiary was eligible at that eligible site as well. It is required for all the telehealth codes except for the Alaska and Hawaii. They use a different modifier since they're under that different program right now. So the next slide here, this kind of lets you know what they're working on in Alaska and Hawaii that they're hoping to bring to other states. I know that the store and forward was something that the providers right now are giving a lot of really good feedback. Actually, I'm going out to Hawaii in a couple weeks, so I'm going to be able to meet with those providers out there to see how how they're liking the store and forward. So pretty much it's exactly as it sounds. Information, the patient records for the provider, and the provider can review that information later and then forward information back to the patient that way. So it's not done in real time. This is the other, the new joint model that they are currently working on. This is backwards here. It's CJR is what it is. It is including 9 post-discharge home visits. So they're seeing if they bundle in all of these services, is it going to be, one, cost efficient for Medicare and also for the patient as well, so they're not paying coinsurance every single time. It's going to be on a bundled payment. And it's just specifically on lower extremity joint replacement. And this is the list of all of the model locations right now of where we are currently have this option for you as a provider to be able to bill. You would know if one of these, because all they release to us is just the cities. So you would know if your facility was one that was currently involved with this. There is a website on this slide here to the innovation.cms that will link you to all of the facilities that are currently able to bill for this bundled payment. So hopefully it does well, and they will look into possibly even extending the bundled payment, not just for the lower extremity joint replacement, but for other services as well. So these are the telehealth codes, and then there is no originating site fee because it's all just going to be bundled into one payment. So we do get a lot of frequently asked questions when it comes to telehealth services. I just threw in a couple of them for you here. So is there a limit on the number of originating sites that can be billed per day, week, or month? And the answer to that is no. There can only just be one originating site per eligible encounter. So if you have an eligible encounter every day, if there's the medical necessity to see this patient every day, you could bill that every day. Most of the time that probably won't happen, but there isn't a limit on the number of those. Question number 2, when you're billing the originating site, would you list the distant site practitioner as the attending provider? And that is correct, because you have to have a rendering provider on all of your claims to Medicare. So on your originating site, because that's your beneficiary one, you're going to put the provider that is actually rendering the services on that claim. This was a big one. We get this question a lot, and people don't. It was a question if they can use Skype or FaceTime, and no, CMS does not allow Skype or FaceTime as a HIPAA compliant method. We also get asked, well, what can we use? And CMS also doesn't tell you what you can use. So it has to be HIPAA compliant, and you have to have your audio and your video. But they're not sticking to just one company, obviously, that does these services. And then if a telehealth service was provided from an unauthorized site and the GUI was added, would it deny as patient or provider responsibility? If you're adding the GUI modifier with any Medicare claim, that will be always denied out as patient responsibility with the use of that ABN. So these next couple slides here, just a couple of resources for you guys. This is the telehealth services booklet that's out on CMS's website. It lists pretty much everything that I just went over today, and it'll also give you links to their other like articles and things like that, and also CRs and other changes and stuff. Also out on our website, out on Noridian, Medicare.com, we have a whole browse by topic of telehealth, which includes a lot of our presentations and our past Q&As that we've had when we do our webinars for these services, and then also CMS some links to that IOM as well. And then CMS also has a dedicated website specifically for telehealth, and then also this Medicare Learning article is also something that you might find helpful. So with that, I thank you guys for listening to some information about Medicare. Anybody has any questions, I'll gladly take them.
So a lot of people are, complaining about, well, Medicare doesn't pay for telehealth when patients at home most of the time, and there's some pending legislation. Do you have a personal opinion on if they're eventually going to do that, and maybe when they're going to do that?
I know that it has been. That's a frequent question, and we do get that one a lot at our conferences and webinars and such. And we, as a contractor, can only relay that information back to CMS. So we give them the feedback when it comes to the comment periods when they release them for change requests and things like that. So it has been expressed to CMS that we would like a beneficiary's home to be an originating site.
Yeah, thank you. For your slide 23, you talked about the store and forward telehealth.
Yes.
Are a lot of those services already covered as a remote interpretive study, like radiology or pathology that's done async?
Yeah, but to use it as like in Hawaii and Alaska, they're using the store and forward for everything. So they can use it for any telehealth service. So just your follow-up office visits and things like that. But you are correct about that.
Okay, so for like a radiology, you need not use any of those modifiers, right? Like
No. No, yeah, this is strictly just for if you're billing a telehealth service that would qualify for those 2 states.
I assume the teaching physician rules are eligible for telehealth as long as you meet all the guidelines?
Yes, yeah, all the incident 2 criteria, definitely. As long as it's met, then you can bill that while you're billing your telehealth as well.
The other question was, on your list of providers, I didn't see dentists listed there.
That is because a dentist is not a covered practitioner in general for Medicare. There's only certain times that a dentist can perform services for Medicare. We don't cover anything routine dental. So the only time that a dentist is ever covered is during, let's say, extractions of teeth before chemotherapy.
Yeah. Well, like, for example, we run a chronic pain clinic. We're dentists. And we do E&M codes and injections and a variety of other things that we bill for Medicare. So that seems like it should be covered. We are already billing for Medicare. Why isn't it covered under telehealth? Well,
because a dentist in general is not an eligible practitioner for Medicare. A dentist can't bill E&M codes.
Yes, they do. All across the country they do.
That's interesting, because that is one thing that I've always known, is that dentists, it's not an eligible. I'll pull up our website too, so that you can see that information on there. Yeah, most definitely. Yeah, no, I'll pull it up for you.
Because there's probably hundreds of dentists who are doing this illegally, if you're right.
Yes,
or
because
you're
they
wrong.
cannot enroll. Exactly. Yes.
So I'd
Yeah.
like to know that answer.
Yeah, I'll pull you up the list that we have on our website for non-eligible providers.
Thank you.
You're welcome.
CapEx for equipment for telehealth versus OpEx for telehealth operating costs. Any thoughts on reflections? How is there any way to deal with the equipment costs? Or thoughts on the direction?
Yeah, that's unfortunately that's nothing on my side of it, because I don't deal directly with that part of it. I just deal directly with Part B claims that are coming in and teaching providers how to bill your Medicare claims correctly and get reimbursed.
So do you have to be the established primary provider to bill telehealth, or can you say somebody calls you randomly and sets up an appointment for a telehealth visit?
You would have to be established with that patient, and then you could then do telehealth services after that.
Just a question about why differentiating between telehealth and in-office visit. It seems like it makes the process more complicated, and the need is definitely there for providers to provide treatment. Why not make it all the same?
I think that with the CPT codes that CMS has selected for the ones that you're eligible to bill, they do that based off of medical necessity. That's how CMS rules everything, is based off of medical necessity. And if they feel that those codes can effectively be done via telehealth. I would say for things like that, definitely, that I would take advantage of that open policy that they have when they put out their initial rule. There's a comment period that you can submit questions and ask to add CPT codes. I would definitely take advantage of that as providers, because we can't see, all we see is the claims that are coming in, but we can't see what might be more effective for you as a provider. So I would definitely take advantage of any type that there's an open comment period on things like that, because that's the only time that we would be able to hear from you as a provider.
Okay, one last question.
Can you describe how the program like CJR gets started, and is there any plan to actually add more type of procedures like that to the program?
That's what they're trying to do. So they're seeing how well this model works based on the joint replacement on the lower extremities, and they're seeing how it will be, how effective will it be? Will it be cost efficient for Medicare as well as a provider? And it just was implemented the beginning of this year. So they usually let those programs run for a good 18, 24 months before they make any types of changes or further implementations on it. So I would give it a little while, but you can definitely track the progress and things, and they add information constantly to their specific website that they have out on CMS's website.
Great. Thank you so much.
Thank you.